Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
Okay, so my name's Yishay, and it's my great pleasure, along with my co-chairs, David Overman and Kisaburo Sakamoto, to welcome you to the World University for Pediatric and Congenital Heart Surgery 10th educational webinar. The subject for today is Atrioventricular Septal Defects, the basics. During this 2.5-hour session, we're honored to have a world expert international faculty of members who will discuss important topics related to the anatomy, management, and surgery for AVSD. Each presentation will be approximately 8 minutes, with 6 minutes being reserved for questions from the audience. Please note that in order to maximize everyone's learning enjoyment of the educational material, the audience computer microphones will be muted. However, we do encourage you to ask your questions through your chat function on Zoom. And so in order to submit a question, open the chat function, select the moderator's name, and type in your question and press enter on your keyboard. Please also note that the program is recorded and will be available on the World University website. So let's get started with the program. Our first speaker today is the distinguished Professor Bob Anderson from the UK, cardiac anatomist and morphologist extraordinaire, who will talk about the embryology, morphology, and classification of atrioventricular septal defects.
Hello, all, ladies and gentlemen. It's my task to help you understand atrioventricular septal defect. I have no disclosures, but I should tell you that I would not have been able to make this presentation without the help of Aditya Dodamani. Aditya is currently training as a medical student, but he has helped me previously with the boot camps I've prepared for the Indian Association of Cardiovascular and Thoracic Surgery. So what we're talking about is the channel that permits shunting between the atrial and ventricular chambers. Very rarely we can find that in the setting of separate atrioventricular junctions, and that's what we call the Cabodi defects. But much more frequently, what we are talking about is the presence of shunting in the setting of a common atrioventricular junction. And that's what we'll concentrate upon. But I'm going to try to interpret that morphology for you in the setting of what we now know about development, because that permits us to understand the arrangement of such shunting in the presence of separate atrioventricular junctions versus the common atrioventricular junction. Because we know that in normal development, the atrioventricular septum is formed as the embryo closes the persisting embryonic interventricular communication. And we know that that eventually becomes the membranous septum. Now, we've now learned that as the embryo closes that persisting interventricular communication, surprisingly, there still seems to be a common atrioventricular junction, but with separate right and left orifices. So this is what we're talking about. This is how the embryonic interventricular communication is closed in the mouse heart. In fact, there's been marked remolding of the initial embryonic interventricular communication, and its larger part, as shown here by the double-headed green arrow, will become the outflow tract, the left ventricle. So the embryo closes the persisting communication between the aortic root and the right ventricle, and we call that the tertiary interventricular communication. This is what it looks like in the human heart at the end of the 7th week of development, just after the embryo has closed that tertiary interventricular communication. The pulmonary root is now arising from the right ventricle. And there is the channel that the embryo has created between the aortic root and the left ventricle. And there are the tubercles of the atrioventricular cushions that close that tertiary interventricular communication to become the membranous part of the septum. We can reconstruct that and show you what it looks like relative to the ventricular septum itself. So there is the aortic root, and you see it is to the right of the ventricular septum, because the embryo has created this channel connecting the aortic root to the left ventricle, and then closing the channel that was present between the aortic root and the right ventricle. And it is that process that remodels the secondary interventricular communication to become the left ventricular outflow tract. Now, this is that same data set that we've reoriented so that you can see the atrioventricular junction. In fact, we've colored in there in yellow the atrioventricular canal myocardium, and surprisingly, you see it's still relatively creating a common junction. But here is the key point. The cushions themselves have fused to separate that junction into right and left atrioventricular orifices, but the aortic root has not wedged itself yet between the left side and the ventricular septum. And now you see here the conduction axis, which is very much at the crux of the heart, as we know it is in the lesion we're going to be discussing, atrioventricular septal defect with common atrioventricular junction. But there is one key additional point, because already at this stage of development, this structure, which I've shown in purpley pink, vestibular spine, has grown in from the pharyngeal mesenchyme to bind together the central part of the atrioventricular junction. And it is this growth of this structure, which we call the vestibular spine, that then permits the atrioventricular junctions themselves to expand. So the key stage of development is the binding together, middle of the junction. Ongoing expansion produces the inferior pyramidal space, permits the aortic root to wedge itself between the left side of the developing mitral valve and the septum, and muscularizes to form the anteroinferior buttress, which is the true second atrial septum. So after all this has taken place, it is that membranous septum, which becomes divided by the hinge tricuspid valve into atrioventricular and interventricular components. It is only the atrioventricular component of that membranous septum that is a true atrioventricular septum. And it is in those rare instances where there is deficiency of this part that we have the Gabodi defect. So this is what the direct Gabodi defect looks like. I've never seen it myself. This is based on the experience of my good friend and colleague Carl Backer, who repaired several cases whilst he was working at Lurie Children's Hospital in Chicago. There is the deficiency at the site of the atrioventricular membrane septum, but note the remainder of the septal structures are intact. So this is very much the rarest form of atrioventricular septal defect. Much more frequently, and what we are now discussing is the situation in which we have deficient atrioventricular septation in the setting of a common atrioventricular junction. And what we've seen is that the underlying problem is the failure of the vestibular spine to bind together the center point of the developing atrioventricular junctions. So when that binding does not exist, the junction can continue to expand to produce the common entity we're going to be discussing very shortly. And it removes the potential for the aortic root. Also produces disproportion in the inlet and outlet dimensions of the ventricular septum. And these are the phenotypic feature of the lesion we're now going to discuss. One other important point, even though there is a common atrioventricular junction, as we have seen, the atrioventricular cushions can still fuse to produce separate orifices for the right and left ventricles. And we've seen that during normal development. And that is what we see in the setting of the so-called ostium primum defect. I'm sure many of you still think of that as an atrial septal defect, but what we're going to show you is that, in fact, it is an atrioventricular septal defect, but one in which shunting is confined at atrial level. So let's put all of that into the context of the anatomy of these lesions. Now, this is what you see in the entity that I'm sure many of you call the complete atrioventricular septal defect. There is its major phenotypic feature, the commonality of the atrioventricular junction. There is its second feature, the unwedging of the aortic root. I'm showing you this, of course, from the atrial aspect. So you see the left side of the heart to your left hand, the right side to the right hand. And the essential feature of the complete defect is that when we look in the plane of the ventricular septum, we also have a common valvar orifice within the common junction. Compare that with what we see in the ostium primum defect. And I hope you will agree that the junction is just as common here as in the heart I showed you just a moment ago, and there is just as much unwedging of the aortic root. The essential feature now is that in the plane of the ventricular septum, a tongue of tissue has divided the common atrioventricular junction into separate orifices for the right and left ventricles. So all depends for understanding and appreciating the arrangement of the leaflets. I'm now going to show you that as it would be seen by the echocardiographer. So we're looking up at the base of the heart from the ventricular apex. So now the right side is to your left hand. There is the plane of the septum. Two of the leaflets that guard the common atrioventricular junction are found within the right ventricle. The major leaflets, however, bridge the ventricular septum. And then the final leaflet is a mural leaflet in the left ventricle, but it is but a small proportion in terms of dimensions of the mural leaflet you see in the normal mitral valve. And the space in the middle of the common atrioventricular junction is the zone of apposition between the superior and the inferior bridging leaflets. And that means that when you as surgeons look at the left half of this common atrioventricular junction, you see the left ventricular components of those leaflets that bridge the ventricular septum together with the small mural leaflet. And so for you as surgeons, another key point to note, the left atrioventricular valve closes in trifoliate fashion. And I think we all now recognize that it is a mistake to think of this as a so-called cleft mitral valve. In fact, it is the trifoliate left atrioventricular valve. Equally important is to understand what determines the potential for shunting through the defect, because that is perhaps the major feature that determines the difference between the phenotypes. And what I can show you is that this depends on the relationship of the valvar leaflets to the septal structures, such that shunting across the defect may be exclusively at atrial level, much more frequently at both atrial and ventricular levels, rarely exclusively at ventricular level, but on occasion, there may be no potential shunting at all because the defect has closed spontaneously. So if we look at a four-chamber diagram, here is the atrioventricular septal defect. And in the majority of instances, those bridging leaflets will float within defect. And then we have the shunting for both atrial and ventricular communications. But if the bridging leaflets are firmly attached to the crest of the ventricular septum, as we see in the so-called ostium primum defect, then shunting through the atrioventricular septal defect will be confined at atrial level, but it is still an atrioventricular septal defect because we still have a common atrioventricular junction. Exactly the same situation when we have the bridging leaflets attached to the underside of the atrial septum. Now, shunting will be confined at ventricular level, but as long as we have the common atrioventricular junction with the trifoliate left atrioventricular valve, still we are dealing with an atrioventricular septal defect in the setting of common atrioventricular junction. And then remember those very rare cases in which the atrioventricular septal defect can close spontaneously. So what I've hoped I've shown you is that the phenotypic feature of the commonest lesion in which there is the potential for atrioventricular shunting is the commonality of the atrioventricular junction. To understand the phenotypic variation, we need to look at those leaflets bridge the ventricular septum. Are they attached to each other so that we have separate valvar orifices within the common junction, or is there a common valvar orifice? Equally important, how do they relate to the septal structures themselves, because that will determine the level of shunting. I haven't had time to discuss the relationships of the common junction to the ventricular mass, but what I hope I have been able to show you is that all of these variations now can readily be understood on the basis of our knowledge of normal cardiac development.
Well, Professor Anderson, thank you so much for another knowledge-packed talk. There's never a time I don't learn something from you, and it's really a privilege and an honor to have you part of the webinar. There are no questions from the chat room, and we are at about 15 minutes. So I think we'll our experience is that questions trickle in throughout the webinar, and we'll probably be returning to ask you a few morphologic questions before we end today. So thank you again.
Excuse me if I depart relatively early after I listen to Meryl's talk. So if people want to ask me questions, maybe they can give you the questions, and then after Meryl's talk, if any come up, I'll answer them then, because I have another binding commitment I must take care of.
Very good. Okay, thanks much, Bob. Appreciate it.
So our next speaker is Dr. Meryl Cohen, who's a pediatric cardiologist and the Associate Chief of the Division of Cardiology in the Cardiac Center at the Children's Hospital of Philadelphia, and also Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And she'll be talking about imaging for atrioventricular septal defects, including echo, MRI, and catheterization.
Good morning, everyone. I want to thank the organizing committee for inviting me to speak to you this morning, and I have no disclosures. In talking about imaging of atrioventricular septal defect, we must identify some common themes. All patients with AV septal defect have a common atrioventricular junction or annulus, and this helps us in our classification. So we can classify them as having complete form of the defect, in which they have generally a large ventricular septal defect, partial form of the defect where there's no VSD component, transitional form of the defect where there is generally a restrictive ventricular septal defect, and a more controversial term, intermediate, which can be different in different institutions, but to me means that you can have a common junction with two orifices, but the orifices are because of fusion of the superior and inferior bridging leaflet. So this is less common. We can also classify these patients by balance. Generally, the majority of patients are balanced at the ventricular level, meaning the common AV valve opens equally to both ventricles. But you can have unbalance at the atrial level, so-called double outlet atrium. And about 10% of patients have unbalance at the ventricular level. Fortunately, the majority of patients with AV septal defect require only echocardiography to be performed prior to their surgery. And here is the crux of the problem with AV septal defect. Here you see a normal heart on the left side of the screen, and you can see that the aorta sits wedged between the tricuspid and mitral valves. Whereas in AV septal defect, you have a common annulus, which causes the aorta to be unwedged, if you will, further anterior. In addition, the other common feature is that the patient has, in addition to a common annulus, they often have a common valve with a superior bridging leaflet, an inferior bridging leaflet, and mural leaflets. The other common feature is associated with this common annulus, and that's elongation of the left ventricular outflow tract, which you see in this subxiphoid left anterior oblique view. You can see that the aorta looks elongated, and that is because in AV septal defect, the inflow from the AV valve to the apex is shorter than the outflow. So that left ventricular outflow tract obstruction is common, and it can occur after repair. The subxiphoid views are really our best view to identify and highlight the AV valve in AV septal defect. As you see here, you see the superior bridging leaflet and the inferior bridging leaflet and the mural leaflets, and looks very much like the pathological specimen you see on the right. These are en face views of the valve that you see in the LAO view. But these are not good views to assess the VSD size because the echo probe is sweeping through the ventricular septal defect. So we often use the apical four-chamber view to assess the size of the atrioventricular septal defect, the large hole in the middle of the heart. And we determine the level of shunting based on where the AV valve is located within that AV septal defect, as you see here on the left, in the echo, and in the path specimen on the right. We also use this view to assess AV valve regurgitation and the location of those jets. We can use the subxiphoid views to identify Rastelli classification. Here you see that the superior bridging leaflet has an attachment, or is divided, if you will, at the ventricular septum. And over here, you have a patient with a free-floating superior bridging leaflet, no attachment. Of note, type B is quite rare and can be quite difficult for us to diagnose by two-dimensional echocardiography. 3D echocardiography has really enhanced our understanding of AV septal defect. It's a pathologic specimen in motion, if you will. And so here you can see a patient who's in an apical four-chamber view where we've cut away the free walls of the ventricles, and we've turned to look at the AV septal defect en face, which you see this large hole and the AV valve sitting in the middle with an atrial and ventricular level shunt. It's very common for these patients to have AV valve regurgitation, which can be quite troublesome. And often that regurgitation occurs at the coaptation site of the superior and inferior bridging leaflets, but can actually occur anywhere. Reoperation on particularly the left AV valve in these patients can be as high as 30% in some studies. Again, three-dimensional echocardiography has really enhanced our understanding of leaflet and commissure morphology. And a new innovation, 3D color, has really allowed us to start locating the AV valve jets to help our surgeons when they're doing valvotomies in these patients. The very rare patient who has no primum defect but has a large VSD must be distinguished from an inlet type VSD, and the distinction is that these patients always have a common annulus or common junction. The valve, instead of sitting in the middle of the AV septal defect, is adherent to the atrial septum in this case, but the left AV valve still remains trifoliate, and these can be somewhat challenging to repair. Partial AV septal defect is often diagnosed in subxiphoid view as well. Here you see a path specimen with the secondary septum and primary septum and the primum atrial septal defect. And so what's missing in these patients is the canal portion of the atrial septum, which you see missing here. The inferior border of the defect is the AV valve, and subxiphoid views really help us understand this with size and direction of flow. And the subxiphoid short axis view really helps us distinguish between the normal heart and the AV septal defect. Here you see a normal mitral valve, and you can see that orientation of the valve with the anterior leaflet in the parallel location to the ventricular septum. Whereas in a patient with AV septal defect, you see a so-called cleft, which is really the space between the superior and inferior bridging leaflet, but that cleft is directed towards the ventricular septum in a perpendicular fashion, as you see from the LV view in this path specimen. So this is a way that we can really make this distinction. There are variations of this disease, and in apical four-chamber view, you can see in some cases, the AV valve is densely adherent to the ventricular septum with no room for a VSD whatsoever, as you see in this path specimen. But in some cases, there probably was a VSD at some point, but it has been filled in with AV valve tissue. And that same 3D view that I showed you earlier, now in a patient with partial AV septal defect, you can see when we look on FOSS at the AV septal defect now, the AV valve is densely adherent to the ventricular septum, so there is only an ASD component. And this really highlights the notion of a common annulus, but two orifices in partial defect. Here you see the valve closed. It looks like a common annulus and common valve in that you can see a superior bridging leaflet and an inferior bridging leaflet and mural leaflets. But when the valve is open, you can clearly identify that it has been divided at the ventricular septum, and the left-sided AV valve has a truly trifoliate nature to it. And you can see it opening and closing on the right here. And that so-called cleft is directed towards the ventricular septum. Just briefly, you can have unbalanced AV septal defect. We don't really have time to talk about this, but here's an example of double outlet right atrium where the atrial septum is malaligned from the ventricular septum such that the right atrium can empty into both ventricles. You can have unbalance at the ventricular level, unbalance to the right or right dominant where the left ventricle is hypoplastic, or left dominant where the right ventricle is hypoplastic. And then briefly, let's just touch upon CMR. In AV septal defects, you can identify inflow into the ventricles, which is quite useful in patients who have unbalance. And then you can do velocity mapping to help determine regurgitant fraction when there's concern about AV valve regurgitation. And I just also point your attention to this example here where the heart is extremely enlarged in this unbalanced AV septal defect with a large atrium. And what you should notice here is that the left pulmonary veins have really become compressed at the spine. And these are some of the subtleties that you can pick up by CMR that you may not pick up in echo. So imaging of AV septal defect, in most cases, echo is adequate for complete diagnosis, but certainly 3D echocardiography has enhanced our understanding of the anatomy and allows for more complete imaging of the valves. CMR is typically used in high-risk patients and for quantitative assessments, such as ventricular volumes in unbalanced AV septal defect, AV valve regurgitant fraction when we're concerned about the regurgitation, and an estimate of cardiac index. And we really reserve cath or angiography for rarely used for diagnostic purposes, but used in, again, certain settings, such as late presentation when we're concerned and have to measure the pulmonary vascular resistance, or in those small group of patients with AV septal defects who have pulmonary vein stenosis or have complex left ventricular outflow tract obstruction. I'll leave it at that, and thank you for your time.
Meryl, thank you so much. A great talk, and as usual, and we are so lucky to have you be a part of the session. So thanks for
No problem. And Professor Anderson and I are in agreement about this particular lesion. Would you say so, Professor Anderson?
Almost.
Uh-oh.
Uh-oh. Well, speaking of Professor Anderson, there are several questions that have come up since the end of his talk. Bob, perhaps you could address a couple of them in the time we have, and if some come in for Meryl, we'll get to those as well. The first is from Chark Ebels, a somewhat provocative question. And that is that have new embryologic insights changed the appreciation of the basic AVSD morphology?
On the contrary, I think if anything, they have strengthened it. I think in one of Meryl's pictures, she showed exquisitely what she called the gooseneck malformation. And anybody who was watching it will have noticed the similarity between the human heart prior, at the stage at which the aorta is already connected to the left ventricle, but has yet to be insinuated between the developing mitral valve and the septum. So what I think that our insights have shown us is that it is the ongoing remodeling that takes place after the vestibular spine, which is what Meryl called the septum of the atrioventricular canal. We know that it is absence, it is failure of formation of that septum of the atrioventricular canal, the vestibular spine, that produces the lesion. And it is only when the middle of the heart has been bound together by the vestibular spine that the aortic root is then able to insinuate itself between the mitral valve and the septum. So that insight to me has strengthened my understanding of the phenotypic features, because in fact the phenotypic features are what you see in the developing heart prior to the remodeling of the aortic root so that it reaches its normal position within the left ventricle.
Very good. Meryl had mentioned intermediate form of atrioventricular septal defect, sometimes called transitional. And one of our questions is about that. I would like Professor Anderson to comment on the described entity called transitional AVSD.
I think, again, Meryl provided the answer to that because her images were truly spectacular. I think, as she says, the three-dimensional images have brought so much more to the understanding of the lesion. And at one point during her presentation, she said there is the big hole in the middle of the heart, and that is the atrioventricular septal defect. And what she then showed was that the bridging leaflets oftentimes float within that atrioventricular septal defect. But throughout her talk, she was speaking of the atrial septal defect and the ventricular septal defect. And when I said we are almost in agreement, this is the point at which we are almost there, because I would put to Meryl that what she calls the atrial septal defect is in fact the interatrial component of the atrioventricular septal defect. And what she called the ventricular septal defect is the ventricular component of the atrioventricular septal defect. And if we are to get full understanding I think we have to appreciate that that big hole she described is indeed the atrioventricular septal defect, and the transitional forms depend on what is happening to the superior and the bridging leaflets, to each other, and to the crest of the ventricular septum, because as she said, there are various types. And she said her transitional form, correct me if I'm wrong here, Meryl, it might have been the intermediate form. I think it was the intermediate form, is where you have separate valvar orifices, but a small interventricular component. And then you said the transitional form are those where the two bridging leaflets can be bound down to the crest of the ventricular septum. So all the shunting is at atrial level, but still there is a common valvar orifice. And I would take care of those not by using the terms transitional or intermediate, because as Meryl said, those definitions depend where you are, which unit you work in. I would simply describe whether we have a common junction or separate valvar orifices, and then the level of shunting through the atrioventricular septal defect. And Meryl might want to comment further on that.
Yeah, thank you, Bob. So first of all, I'm in agreement with you that it is an atrioventricular septal defect. And when I said an atrial defect and a ventricular defect, I think really the better term to say is atrial level shunt and ventricular level shunt. That can distinguish it, because it is always an atrioventricular septal defect, no matter where the AV valve sits within it. So I think we're in agreement on that. For me, transitional, and you're right, it's all how you describe it, but the distinction, I think the takeaway here is that there's always a common AV junction in all spectrums of this disease. And some people have in the past had difficulty understanding that, particularly when you had what we called an ostium primum ASD, because always in an ostium primum ASD, you have an atrioventricular septal defect. But in the transitional form, you have multiple cords attached to the ventricular septum so that there is shunting between those cords. I didn't have time to show that in this presentation. And then we've seen rarely, and I'm sure you've seen in specimens, patients who have a common junction where there's a large VSD component, but the superior and inferior bridging leaflets are fused together to cause two orifices. Yeah. So you can have common junction with common valve. You can have common junction with two annuli and two valves, I'm sorry. And those are the two ways that it can happen, either dense adherence to the ventricular septum, dense adherence to the atrial septum, or fusion between the superior and inferior bridging leaflets. I hope you would agree with that.
Indeed, I agree 100%. But I think that there is so much confusion within the literature that it is better to take the time and to describe it as you have just described it, rather than trying to put a label on it. Because as we've seen from the questions, they mean different things to different people. And as you said yourself, it depends which definition you want to use. So in those circumstances, take the time and tell your surgeon exactly what's going on, because your pictures are, as I say, truly spectacular, because you can see all these things now, and there's no guessing about it, and you can show them the images, your 3D pictures, and now, as you say, you have 3D color mapping, and it's truly spectacular.
Very good, thanks. I think all the surgeons on the call would agree. Tell your surgeon exactly what's going on. That's the take-home message here. Well, we're actually a little over time. We're going to have, there's many other questions stimulated by both of you guys, and just a great start to the webinar. So thank you very much, but we're going to have to move on.
So our next speaker is Dr. Ignacio Juaneda, who's head of pediatric heart surgery at Hospital de Niños de la Santa Sima Trinidad in Cordoba in Argentina, and also head of congenital heart surgery at the Hospital Privado Universitario de Cordoba, and deputy chair of congenital heart disease at the University Institute of Biologic Sciences of Cordoba. He'll be speaking to us today about the single and double patch repair techniques for complete atrioventricular septal defects.
Atrioventricular septal defect repair, single patch and two patch technique. Complete atrioventricular septal defects include deficiencies in the inferior portion of the atrial septum, the inflow portion of the ventricular septum, and the tissue forming the left and right atrioventricular valve. They have been classified into partial, incomplete, complete, being the last ones when he has an ostium primum ASD, a common AV valve, VSD, a superior and inferior bridging leaflet with two additional right-sided lateral and anterior superior leaflets in the left lateral or mural leaflet. The study classified complete atrioventricular septal defects into three types, type A, type B, or type C, according to the degree of the bridging and cordon attachments of the common AV valve leaflets. 1958, they have described the position of the AV node and the bundle of His. This is placed posteriorly and lies between the coronary sinus and the VSD. These are the techniques described throughout history. We're going to talk about the classic single patch repair and the two patch repair. For the classic single patch repair, a patch of autologous pericardium or diaphragm is used to cover both the ventricular and atrial septal defects. It's important to determine the position of the mitral cleft and the superior bridging leaflet with respect to the crest of the interventricular septum. Attention needs to be paid to the width of the patch with respect to the width of the AV canal defect to prevent mitral regurgitation caused by distortion of the leaflets. For the classic single patch repair, starts with the testing of the AV valve. Stitch is given. It's going to be the left side component of the AV canal and the right side component. After that, the superior bridging leaflet is incised, the same as the inferior one. And the pericardium is sutured to the crest of the septum, with stitches given on the right side aspect of the interventricular septum to avoid the conduction tissue. After that, the leaflets, both the superior and inferior, are resuspended to the patch. And after that, the cleft is closed with interrupted or random suture. The premium ASD is closed with two sutures, random sutures from each side to complete the closure of the ASD. For the two-patch repair, the surgery starts as well with the saline test of the AV valve. Stitches given to the valve is going to be the left side component and the right side component of the AV canal. And the VSD size is measured with two stitches to measure the length and the depth. To cut and precisely trim the patch, there can be PTFE or diaphragm. You can use either interrupted or random sutures, as in this case, in the Gore-Tex or PTF patch. For the ASD, after the VSD patch is descended and tied, several matrices interrupted problem sutures are given between the VSD patch, the AV valve, and the autologous pericardium patch. This is going to be used to close the ASD. After this is done, the cleft is assessed, closed, and the left atrioventricular valve is assessed for competence. The Gore-Tex or the problem sutures, there can be 5 or 6 or 7 of them can be given, either interrupted or random fashion. The Z-score of the mitral valve is tested. Competence is assessed with a saline test, and additional commissures stitches can be given to improve the coaptation of the valve. And it's important to give stitches up to the cord. For the right atrioventricular valve assessment, stitches are given between the anterior and the posterior valves to improve the competence of the right component. After this is done, then the ASD is closed with 2 random sutures from each side, and needs to pay attention to the AV node, which lies close to the coronary sinus, that we preferably leave it on the right side aspect of the atrium. This is a patient we operated, 5 kilograms, 4-month-old, Raceli type C. So once we open the atrium, we assess the AV valve. This is a Raceli type C. Stitches were given on the interventricular septum crest on the right side aspect with interrupted plegated 5 sutures. These sutures were passed through the ventricular septum, then through the VSD PTFE 0.5 millimeter patch. And then all these sutures were tied down to close the VSD. Once this is done, we use another series of interrupted 5-0 mattress problem sutures. It gives stitches on the PTFE, the valve, and the autologous pericardium. We do this to tie down the autologous pericardium patch and divide the right side, left side. So the left side component, followed by assessing the cleft that we generally close with interrupted 5-0 or 6-0 problem sutures. So our experience consists of 63 patients with the from 2014 to 2021. We had 3 patients who had associated lesions. This is our serious patient's age and weight. And we generally operated on patients who had Rasteli type A, 22 patients had Rasteli type C, and 2 patients Rasteli type B. And our series consists mainly of 2-patch technique, although 10 patients had the modified single patch. These are different series from different institutions comparing single patch and 2-patch technique in terms of operative mortality, mitral insufficiency, and 3rd-degree AV block. This series from Wisconsin reported their experience in 2 areas using a 1-patch or a 2-patch techniques, and they really show improvement in mortality when using the 2-patch techniques in the second era of their series. The group from Melbourne, Australia, reported 138 patients. They mainly used the 2-patch technique, really good results, and only 1 patient with a complete heart block. Operative mortality was low. The freedom from reoperation at 80 years was 84%, and being more than 6 months showing them to have more risk of reoperation. This report with more than 800 patients in the last 25 years from Australia, they compared modified single patch with 2-patch technique, and they find no difference in the unmatched survival and no significant difference between repair techniques in reoperation for left atrioventricular valve regurgitation or left ventricular outflow tract obstruction. There was no different need for pacemaker implantation. This meta-analysis from 2019 comparing single patch versus 2-patch repair for atrioventricular septal defects examined pump times, cross-clamp times, ICU stay, ventilation time, reoperation for LVOTO or LAVVR, and the need for pacemaker implantation and mortality. Almost equally distributed among surgical techniques. They showed there were less pump times and less cross-clamp times. And although there was no difference for pacemaker implantation, length of stay, reoperation, or mortality for both techniques. This is another meta-analysis of 15 publications comparing single patch and 2-patch techniques. Different countries, more than 1,000 patients. And this meta-analysis demonstrated again that there was when the VSD size were smaller, they tend to use a modified single patch. The pump times, cross-clamp times, lengths of stay were shorter in the modified single patch. There were no difference in the post-operative outcome. So in conclusion, improvement in results of the repair of the complete atrioventricular septal defect has permitted primary repair in infancy to become the procedure of choice. The choice of the 2-patch technique or the single patch techniques according to the surgeon's preference, the confidence, and school. Small VSDs tends to be addressed with the modified single patch, and the 2-patch technique allows for best exposure of the AV valve and is our preference. And regardless of the technique, the goal is to address the insufficiency to avoid complete heart block, to avoid left ventricular outflow tract obstruction, left atrioventricular valve regurgitation, and to avoid residual effects. Thank you very much.
Thanks, Ignacio. That's a great talk. I think what we might do is take Dr. Nicholson's talk and then combine the questions for both you and he, because many of them are about selection of operation et cetera. And his is about modified single patch. But before we do that, there was one question about your use of PTFE material for VSD closure. This is common material. I don't personally use it, so I'm a little curious myself. But the question pointed out that sometimes echo imaging is impaired by the PTFE and shadowing from that. I don't have any experience with that myself, but the question is about the utility of, say, autologous or perhaps bovine pericardium for VSD closure as opposed to the PTFE. And do you have experience with this particular echo impairment problem?
Thank you very much for the questions. We generally use PTFE. We also use Dacron. We've also used bovine pericardium and autologous pericardium. And we haven't seen any real problems in assessing the valves after the repair with the PTFE patch. It's it's a preference to use a PTFE personally, because I feel it gives some kind of structure to the AV canal, and it's easier for the reconstruction. That's the main reason. I have not seen real problems in assessing in the follow-up the valves with any interference secondary to the PTFE as a choice. Generally, when the VSD is small, we tend to use a modified single patch. So we avoid any material there. When the VSD is larger, then we prefer to use a PTFE patch, or, as you said, mentioned, autologous or bovine pericardium.
Very good. Well, Yishay, why don't we move on to Dr. Nicholson's talk, and then we can, Ignacio, if you'll be available for questions after that as well for both of you. I will note
Sure.
that I think Dr. Nicholson has not joined us yet, so we may just be watching his talk and then talking about it amongst ourselves.
Perfect. So our next speaker is Ian Nicholson, who was actually trained by Graham Nunn, and he's now head of cardiac surgery at the Children's Hospital at Westmead in Sydney, Australia. And he's an experienced adult and pediatric congenital heart surgeon. And he, as we've mentioned, will be talking about the modified single patch repair technique for complete AVSDs.
Thank you very much for asking me to present our modified single patch technique for repair of atrioventricular septal defect on this webinar today. My name's Ian Nicholson. I'm an adult and paediatric cardiothoracic surgeon in Sydney, Australia, and I work at the Sydney Children's Hospital Network, based mostly at Westmead Children's Hospital. I have no disclosures to make. The modified single patch technique should really be called the simplified single patch technique. Dr. Graham Nunn, my mentor, developed this technique during my training really in the mid-90s. And I found it quite a simple way to learn how to repair an atrioventricular septal defect, had a much shorter learning curve for me, significantly shorter bypass and cross-clamp times, particularly with a more junior surgeon. And it effectively converts a common atrioventricular septal defect into a large primum atrial septal defect, simplifying very much the repair. Just to reiterate, it's probably been mentioned in previous presentations today, but a complete atrioventricular septal defect involves four main components: closure of an atrial septal defect, as we can see here, the ventricular septal component, which can have varying depths, a common AV valve that needs to be partitioned into two separate valves. And you may borrow a little bit of the right-sided tissue to increase the surface area of the left-sided valve, which is what I do with this technique. And I've got to be careful about outflow tract obstruction, which will be talked about, I'm sure, in other presentations today. This is just a diagram of the two-patch technique. And it's really just to show that in the early 90s, we were using a two-patch technique, and we found that our ventricular septal patch was in fact getting smaller and narrower. And then one day, Graham Nunn decided not to use a patch and sew the leaflets down, got a good result. And then we expanded this with deeper and deeper VSDs, and really applying it to all forms of atrioventricular septal defect, other than tetralogy variants where we might have added a patch in the outflow septum stop. So I think in this diagram, we can see that the single patch technique simplifies this. There's no ventricular septal patch whatsoever. These leaflets are sewn down to the crest of this septum, which is clearly idealized here, but it's often a curved surface area that the leaflets are sewn to the right side of. And in this central diagram here, you can see the leaflets kind of bend in towards the septum, which causes concern for people that this might lead to outflow tract obstruction, but this has not been the case in our long-term follow-up, which I'm sure we'll hear about later today. But it converts it into a primum ASD. And this really is just to show the diagram, but the VSD is sewn down to the crest of the septum. It was originally coapting in this plane, but the valve is sewn down to the crest on the right side, and the caudal support for some of that neomitral valve is therefore trapped by that, but the free edge cords are as they were with any other repair. So it's important to close the cleft. And in our follow-up of patients, you'll see that the cleft was closed in almost all of the patients that had a simplified single patch technique, but with the two patch technique performed in some institutions, the cleft is left open, but it must be closed with this approach. So access is through a standard sternotomy, thymus is removed, and a generous patch of untreated autologous pericardium is used. We did not treat the pericardium in any way in any of the patients. It's just placed in saline and had stay sutures on it to make it easy to use. We use del nido cardioplegia almost completely now on all patients, but in the early experience, it was repeated doses of normal cardioplegia, blood cardioplegia previously. Routine atriotomy is performed, retraction sutures are placed. Care taken not to distort the annulus of the valve when you do that. And then the common AV valve is assessed. The caudal supports behind the valve, what's attached to the septum, is there a bare area or not? All those things are important with a two-patch technique, but with the single patch technique, we're sewing the leaflets down to the crest of the septum. So cords that are attached there are of no concern in terms of having to weave a patch in and out of them. The leaflets are just sewn down, and we just take care that the free edge cords are free to work, obviously. The VSD is assessed, make sure there's no outflow extension, and the ASD component. And this is compared to what's seen on echo and discussed preoperatively and intraoperatively. And then the valve is floated with saline to check where it's supported, and then a line of division is determined between left and right sides. And I tend to borrow some of the tissue from the right side of the valve. And that's important, particularly if there's horizontal clefts or multiple caudal type structures that can often be found in the bridging leaflets. And when these are sewn up, you lose some valve area. And so it's important to have enough area to use. So if these clefts are elongated or exaggerated, when you've sewn them together, you shorten the leaflet somewhat. So I think it's good to start with an adequate surface area. So the VSD is closed by placing interrupted sutures on the right side of the crest of the septum. And these sutures are taken then through the leaflet from the ventricular side to the atrial side and placed on hemostats. normally 8 to 10 interrupted sutures are required, and that's normally a pleated Tevdek. And then I do this so then I can assess the valve leaflets to make sure I'm not distorting them, I'm not pulling one towards the inferior margin or the superior margin too much, that the leaflet just gets pushed back in some ways anatomically, so it's not deviated left or right as you look at it as the surgeon. And then I place each suture through the autologous pericardial patch and a dacron strip, which acts as a pledget again on the atrial side, and then tie this down. I think this is important to support the valve leaflet tissue, particularly in the younger children under 3 months of age, particularly where most of the surgery is done nowadays. And as we can see in this diagram, the sutures are taken through that patch of pericardium and through the dacron strip, and it's all tied down, and it anchors the AV valve aspect of the ASD patch. So the leaflets are opposed to the septum, there's no longer any VSD, and you're just left with a primum ASD type patch to complete with the valvular component already anchored there stopped. So you've now effectively got a primum ASD that you have to close and a cleft to close. So the patch is now lifted anteriorly, and you can see in this diagram we have a cleft here, somewhat idealized obviously for the presentation, but this can be of varying lengths, and sometimes it's not particularly a 12 o'clock, 6 o'clock type arrangement. It can be somewhat deviated. But I think it's important to place some stay sutures in the free edge where the last caudal support is, and gentle tensions placed on this so that you can align the valve leaflets. And I use an interrupted 5-0 or 6-0 suture, depending on the integrity of the leaflet tissue. And some surgeons would use a continuous suture also, and we've had no difference in results based on that interrupted or continuous approach. So the cleft is then closed and the ventricles insufflated to check for valve competency. Occasionally, because the leaflet in some ways may be lifted slightly anteriorly, posterior annuloplasties are required, usually in the region of the commissures on either side, to elevate the posterior leaflet. And this normally adds to valve competency. And it's required perhaps in 20 to 30% of the patients. As I've mentioned here, they're usually localized sutures in this region on either side of the valve. But it's not required in all patients, but it's a good technique to improve the competency of the valve. And so now we're left with a primum ASD. As you can see here, the cleft has been closed, and I tend to deviate the patch along the tricuspid annulus and the fibrous portion, go around the triangle of Koch onto the atrial wall here, and then I go into the coronary sinus with these sutures to avoid any sutures anteriorly on the surface of the endocardium here in the atrium. They're in the coronary sinus, and then we transition onto the atrium away from the conduction system. And so this allows the coronary sinus to drain into the right atrium. And then we simply wean from bypass and check for valve competency. As mentioned, occasionally there's a tetralogy variant, and the VSD here is somewhat malaligned, and there's a deficiency of the septum towards the outflow tract. And so here I would place a small patch to close the tetralogy component, if that's the right description, but it basically converts the tetralogy type of AV canal into a more routine canal, if that's an accurate assessment, but a normal scoop. And then the leaflets are sewn down to the crest of the septum and the free edge of that patch that is filled in that deviated component, much like the standard repair. So in summary, I think the simple single patch technique is reproducible. It's a stable repair in the short and the long term, gives a shorter ischemic time. The cleft is closed in all patients, and it's got a much shorter learning curve than a two-patch technique. Thank you very much.
Okay, that was excellent talk by Dr. Nicholson, very complete. Dr. Orr will be Dr. Nicholson for this Q&A. So Ignacio and Yishay will get started. There are many questions now about the various techniques. First off, there were several questions from the doctors Tan and Brockman and Tageldine about selection of operation based on anatomy, principally VSD size. So perhaps both of you could comment on utilization of a modified single patch repair versus a two patch repair in the setting of smaller VSD or transitional AVSD versus large ventricular septal defects, perhaps with an exaggerated subaortic septal scoop. This principally, of course, revolves around the worry about left ventricular outflow tract obstruction, but also distortion of the AV valve apparatus. So what are your thoughts about selection employment of the different operations based on anatomy?
You want to start, Yishay? You can go first.
Okay. So when we were looking at our national results, which obviously has a large number of surgeons, we found that there wasn't really a specific VSD height that people used to select whether they use the modified single patch or double patch. But when you look through the literature, and I guess you look at the subtleties of each heart, there's probably a selection bias towards using a modified single patch technique when the VSD height's probably less than about 10 millimeters. Some would push it a bit further, but I don't think there's a clear definition. And certainly, as Ian said, back when Graham was developing the technique, if you had a big sort of outlet extension of the VSD, he'd tend to put a patch there, but use the modified single patch in the inlet region. So like a bit of a hybrid approach. And certainly I'll tend to select the modified single patch technique more for VSDs that are, 8 to 10 millimeters or less. And the smaller the baby, also we're doing canal repairs, at 5 or 6 weeks of age at 3.5 kilos. And I think the modified single patch technique is really useful for that, because you don't have to struggle to feed a VSD patch between multiple cords, because they're often breast LEAs with a lot of attachments to the crest of the septum. So I think that's sort of my take on all of it.
Yeah, I agree. The VSD size is the main perhaps a reason to choose which technique to use. I think that also the confidence of the surgeon's team or the surgeon's unit is important in which technique to use. I think that the VSD size are when it's bigger, the concern of causing LVOTO perhaps is a reason for which you can use patch, or as you mentioned, a hybrid part of it with a patch, and then pull down some stitches for the AV valve down to the VSD crest. So personally, in our experience and through the places I have trained, which finally guides your decisions in the OR, and being secure in what procedures you are doing. For small VSDs, we tend to do the modified single patch. When cases have a bigger VSD, same numbers, perhaps 10 millimeters or 8 to 10 millimeters, then we're going to put a patch there. But I think finally you have to choose what you are more secure technique for you to use. Is going to be the choice for you and your department, perhaps. I showed many tape papers, and there's no big difference among techniques. So in terms of results, if the technique has shown no difference, perhaps you have to do what you are more comfortable in doing. That would be my home take message.
I think that's really critical. I mean, I think we all agree as surgeons that AVSDs are probably one of the hardest and most challenging intracardiac repairs that we do. And every single repair has to be adapted to the underlying anatomy. So you have to have like this array of techniques and select each one. But yeah, we often have one particular technique that we're most comfortable with. And I think we often fall back on that when it's really challenging. So I think surgeon preference and training is really critical.
Very good. I did want to just note that obviously Graham Nunn's contributions here are very significant. I will say, however, that the operation, just to be clear, the operation was first described by Sewalt and Lillehei in the 50s. And it was one of the first ways that AVSD was operated on. And then in the more recent literature, the first manuscript was from Benson Wilcox in North Carolina. But I think obviously the Nunn, Nicholson, and now Orr experience with it is super important and key to everybody's understanding of it. There's one other question from Dr. Bidaguri about little tricks or techniques for avoiding heart block in repair of complete AVSD. If you guys would share your particular approaches to that. I know Ian's talk did address that tangentially, but.
So I think to emphasize what he said, two of the critical things are really to, whatever technique you're using, keep your suture placement for the VSD patch on the right side of the crest of the septum, and really don't go anywhere near the absolute crest of the septum. So erring a bit towards the right side, particularly down in the inlet region. I guess that's the ventricular area. And then up in the atrium, as Ian described, tracking the right AV valve annulus actually down onto the atrial wall and going down till you get level with the medial wall of the coronary sinus, and then taking your sutures down towards the medial wall of the coronary sinus. Or if you have particular concern and the coronary sinus is very posteriorly displaced, actually routing the coronary sinus to the left atrium. But you have to be careful you don't cause obstruction to the coronary sinus in doing that, which is why we tend to err by going along the medial wall of the sinus, and then that takes you right to the superior crest of the primum ASD.
Ignacio, anything to add to that?
No, I agree. We hardly, I don't remember leaving a coronary sinus on the left side. On the atrium, we usually leave it on the right side. And of course, it's very important to give very shallow bites on the right side aspect of the VSD, and try to keep in mind the drawings, because it's difficult to see the AV node actually, but you can keep in mind where you imagine it go through, and then try to give shallow bites and very small suture if you need, perhaps 6-0 in smaller babies to avoid block.
Very good. Well, I think that does it for questions for these two talks. Thank you very much.
Thank you.
So our next speaker is Dr. Hendrick Mamorare, who is a cardiac surgeon with a long career in congenital heart surgery, working at the Mabonengi Heart and Lung Institute at Netcare Sunninghill Hospital in Johannesburg, South Africa. And he'll be speaking about palliation for both simple and complex atrioventricular septal defects.
Good afternoon. Okay, I would like to thank the organizers for inviting me to say a few words on this complex spectrum of disease. I have no disclosures. We've already had the surgical management of this disease And I'm just going to make a few points about palliation.
Next.
Okay, we can leave it there. Thank you. Thank you. We've already had all the surgical management of this disease spectrum. And this afternoon, I'm left with a very difficult position of trying to say where palliation fits in the whole management strategy. And if you look at this disease entity, pulmonary artery bending still has some way of addressing this disease, but one must take into consideration that there's a decreased need for pulmonary artery bending because of the improvements in surgical techniques and advances in post-operative management. Next slide, please. And we all know that historically, this procedure has been used since 1952. And the purpose, and the main aim, is to decrease the pulmonary blood flow. And as I've said, we use it less and less nowadays, and we would rather use early definitive repair as opposed to using a pulmonary artery bend. And the reason for that is that pulmonary artery bending is not an innocent procedure. And we can see that in neonates and in infants, it's still attended by very high mortality rates. Next slide, please. So what we use for indications nowadays for pulmonary artery bending, again, I need to stress every time we talk about this that primary repair is still preferable. But pulmonary artery bending allows us to do a delayed biventricular repair. And secondly, it can be used as part of a single ventricle palliation. And whenever we cannot decide whether we can go single or biventricular repair, we can use pulmonary artery bending to defer that decision. Next slide, please. Other clinical indications are that in our setting, in less developed communities, we still see babies who present with severe failure to thrive, presenting for the first time, and they might be even be less than 3 months of age, but with severe cardiac failure due to a large defect. Occasionally, you see patients with multiple VSDs, and now and again, we have to defer definitive surgery because the patient has got other associated defects. They might have an intracranial hemorrhage, they might have an examphulus or some other condition that dictates that you should defer the surgery. Pulmonary artery bending can be used as well in very complex AVSDs. For instance, when you have an AVSD as part of a heterotexy. Next slide, please. The decision-making as a result is not as straightforward as one would like it to be. And probably there are other institutions where they wouldn't even consider pulmonary artery bending. It's just that in a setting of where one practices, this is still a very relevant mode of treatment. So to make sure that we use recognized methods of decision-making, we have looked at several studies, but be that as it may, we still advocate primary repair, and a decision-making as to whether we would like to start with a PA band will mostly depend on the morphology and the ventricular balance. There's room for targeted selective use of pulmonary artery bending. I've selected 3 recent studies to try and clarify the decision-making process. The first study So pulmonary artery bending in complete AV canal septal defect. So this group of patients had a pulmonary artery bend preceding the actual biventricular repair. Next, please. And the analysis focused on the surgical outcome, timing of surgery, survival, and atrioventricular valve function. Next. Next, please. There were 50 patients coming out of 28 institutions. The entire cohort of patients were actually 474. 50 patients were considered. And the study period was between 2012 and 2018. The mean age was 1.1 months with a median follow-up duration of 2.1 years. Next, please. Out of these patients, 68% had a biventricular repair, 13% had a univentricular repair, and there was a 12% death rate, with 8% still waiting for definitive surgery. The left AV valve regurgitation stayed the same whether you had a PA band or whether you had a primary repair. Next, please. We can see that survival at 4 years after biventricular repair, which was preceded by a pulmonary artery band, was 93%. Survival at 4 years after primary biventricular repair was almost similar. And this group decided at that stage that pulmonary artery bending is a successful strategy to bridge to a biventricular repair. Now let's look at the next study. The next study, which was done in 2021, also looked at early repair of complete AV canal defects. And they said this has a better survival than a staged repair after pulmonary artery bending. And it's a propensity score match study. Next, please. And there you have a group of 194 patients. Some of those patients were much younger than 3 months. And this study was done between 1990 and 2019. Next, please. Now, the 77, almost 78% primary complete repairs and 22% pulmonary artery band in this cohort of patients. And they also mentioned that the pulmonary artery band group had a lower weight and were much younger. The interstate mortality for the PA band was 18.6%, whereas the early mortality for primary repair was 3.3%. And that is quite persuasive if you compare the two. The survival at 20 years, the primary group, the survival was 94.2, whereas the pulmonary artery band group was 58.4. And when they looked at the reoperation rates for regurgitation of the left AV valve, there was no difference between the two groups. And more importantly, when they looked at the neonatal repair, there were no early deaths. And their survival at 10 years was 100%. And their conclusion obviously was that primary repair of complete AVSD should be the preferred treatment strategy without really going through a pulmonary artery band as an intermediate stage. Next slide, please. The third study, which we used to try and come to some sort of decision as to which way to go when you confronted with a complete AV canal, was the long-term outcome after early repair of complete AVSDs in young infants. And the impressive thing about this study was the age of the patients. we tend, as an institution, we tend to delay repairs until the kids are more than 3 months old. And this is something that I recently learned. This is a 2021 study that you don't actually have to defer the operation simply based on the age or the weight. Now, this study group comes from 2 institutions which looked at a 25-year follow-up repair of AVSDs. And they have a cohort of 304 consecutive patients, and they had less than 3 months old compared to more than 3 months old patients in the study. Next, please. Their operative mortality was 1.6%. Their survival at 20 years was 95.1. Freedom from reoperation of the left AV valve was 92% at 20 years. The younger age was not a risk factor for the above results. Next, please. And in conclusion, sorry, can we go one back? They concluded that primary correction in patients less than 3 months is well tolerated, and one should avoid palliative procedures. I must say, from where I stand, this is still a bit of something to try and emulate, and it's in many ways going to be a very big challenge for us. And it's not fair to say maybe their patient population is not the same as ours, where we tend to see patients late, where there's a fair amount of malnutrition with failure to thrive, where there's ongoing severe chest infections. And if one can do away with that cohort of patients, maybe even in our setting, we can look at trying to emulate what this group has done. And I think this is really a landmark paper that we would like to try and emulate in our daily practice, which is an ongoing challenge. Next slide, please. Now, the next part of palliation for AV canals was really shunts in AVSDs. And I must say, in our daily practice, this is a very rare occurrence where we have to do systemic pulmonary shunts in AVSDs. And occasionally, we see in tetralogy of Fallot, which we have relegated mainly to a single stage repair, but we do still see a very small patient who's deeply cyanosed and requires some months where we do a modified BT shunt and await them to grow, and then they have a complete repair. But the majority of our patients, I would say, undergo a single stage repair. It's very seldom where we see a two-stage repair. Next slide, please. And this is extremely rare, and I think a very poorly understood lesion where you have a combination of an unbalanced AVSD and a truncus arteriosus, where if it overflows, then you use bilateral pulmonary artery bends. And if you're stable for the first 2 or 3 months, then the tendency is to try and resect the pulmonary artery from the trunk and then add a shunt and then wait for a definitive surgery when the patient has grown. Obviously, these patients are going to go a single ventricle route. But I must be honest, these are very rare conditions. I must confess, we don't really understand, and fortunately, we don't see them every day in our practice. So from a point of view of palliation in atrioventricular septal defects, There is no right or wrong way. There are only endpoints that I think we should try and strive to get to. But it mostly depends where you practice, the expertise, and the patient population in your area. Thank you.
Thank you, Hendrick, for a very important talk for many, many participants of World University, particularly those in the developing world. The role of PA band, as you say, has diminished over the decades, but is still a very, very important part of the armamentarium. I wonder if you could address briefly the role in the developing world of the late presenting patient, evaluation of that patient, and the role of pulmonary artery banding in the setting of worries about pulmonary vascular obstructive disease or pulmonary hypertension.
In the setting of a developing world, late presentation is still a major issue. And it's not unusual to see, because the majority of these patients are Down syndrome. It's not unusual to see these children presenting at 9 months and being frankly inoperable because of severe pulmonary hypertension. So whenever we see them and they are more than 6 months old, they invariably end up in a cath lab where we do rigorous pulmonary artery pressure measurements, try and work out the shunts, try and work out everything. And it doesn't really help to push them through to theater without having all the necessary studies done to make sure that they're still operable. And in addition to that, you have other diseases that compound the issue. Just because they're Downs and they have an AV canal doesn't mean they won't be malnourished, they won't have intercurrent infections, they still have all the other burden of disease that you commonly see in developing countries. And therefore, it's very important to make sure that you're taking the right patient to theater before you even embark on the surgery that you want to do. The question of whether you should bend them or not, I must say the majority of patients go straight to, if they are operable, they go straight onto a primary repair. And when they are very small, especially with chest infections, you really pay a price if you put them on bypass. They tend to linger in ICU. The post-operative period becomes really very challenging, and the length of stay in hospital just becomes unbearable for the parents and for everybody involved. So in a nutshell, we try and individualize things. We know what our endpoints should be, and we try and compare to the developed world, but we cannot ignore where we're practicing.
Very good. Thank you very much. Well, we're a little short on time, so we should probably move on. Right, Yishay?
Yep. So our next speaker is Dr. Glen van Arsdell, who's a congenital heart surgeon, very well known, and currently Chief of Congenital Cardiovascular Surgery at the Children's Heart Center at the University of California, Los Angeles. And he was obviously previously head of Division of Cardiovascular Surgery at Sick Kids in Toronto for 17 years. Today, he'll be talking to us about techniques to deal with the challenging situation of severe AV valve regurgitation during primary repair of AVSDs and during the early post-operative period.
Good morning. Atrioventricular septal defects are often fairly straightforward, but often enough they are challenging that I think it's worth discussing strategies and things that I've seen over the course of my career that can be challenges and potential benefits in terms of how we can approach things. So this is an important paper out of Boston showing that about 2/3 of the patients get an adequate repair, about 15% get a perfect repair, and about 5% have real challenges with the repair. And that makes a difference in terms of reoperation. So if you don't have a great repair, you're much more likely to need a reoperation. Textbooks show these classic leaflet morphologies, and what looks like a very simple repair, just close the cleft and things will be perfect. In reality, this is what we see sometimes. Dysplasias of the leaflet on the left with these little tiny nonlinear attachments for the leaflet edges, or actual dysmorphism of the leaflet. And of course, in reality, the clefts are sometimes serpiginous, Y-shaped, or eccentric, and the mural leaflet may be bifid or trifid in its shape, and the cleft may be very long, or it may be so long that there actually is not a mural leaflet at all. And these are all things that we have to navigate in order to be able to successfully take care of these patients. So there can be surgeon-related issues that can cause non-optimal repairs, such as distortion issues, not getting the patch right, not septating in the right place. Or there can be intrinsic problems, such as the dysmorphism and dysplasia that we talked about, prolapse issues, tissue paper quality of the leaflets, and chordal abnormalities. And of course, depending upon how the patients present, there can be varying expectations. On the left, if there's no regurgitation, you would expect a great outcome. On the right, with a lot of regurgitation coming in, it's likely that there are problems with that valve and your outcome may not be quite as good. So what are our tools for complexity? Well, one of the things you can do is undersize the patch a little bit, maybe by about 10%. And what that does is effectively create an annuloplasty to pull the leaflets together so that you can have better coaptation. You can also make a decision in a typical Rastelli type C patient, where do you place the patch? Can you shift it leftward on the leaflet, or can you shift it rightward on the leaflet? And this can sometimes help you in terms of creating enough leaflet in a particular problematic area for coaptation. When there are dysplasias of the leaflet, we can do these repair of the dysplasias by making these small little tiny nonlinear attachments linear by closing and approximating them to themselves. And this can be helpful in terms of coaptation. When there's this dysmorphism, you can actually do edge-to-edge attachments and then add in local annuloplasties, which can sometimes take care of the issues of prolapse and make it better. When you have a double orifice valve, this is a description out of the French group where you can add a patch into the actual double orifice, which can sometimes be beneficial for the patients. I don't have any particular experience with this exact example, but they were able to describe about a 15% reoperation rate using this technique of adding in a patch for the double orifice. One of the things that's really important in repairs is to not have tension. And here's an example of a functional double orifice. This patient had a giant gap in the cleft. It was a late presenting child on the ventilator with a severe regurgitation. And we identified that if we primarily closed the cleft, there would be tension. And therefore, in this region, we added in a patch so that there would not be tension on the leaflet, and wound up with what would be a satisfactory repair, certainly not a perfect repair, but you would take that given what the child came to the operating room with. One of the issues that can cause regurgitation is papillary muscles that are unusual and extend all the way to the leaflet. The Edmonton group has described that partial cleft closure and recognition of this phenomenon can help keep you from having to reoperate and change out the valve. So you can get this very, very thick papillary muscle without any chordal attachment to the leaflet, but effectively papillary muscle attachment to the leaflet. And you need to be able to deal with this in a non-traditional fashion to be able to have success. Of course, preventing leaflet tension, as we mentioned, is very important. When you have thickened leaflets, primary closure of the cleft is not an issue, but if you have these translucent leaflets, then stitching along there can actually cause disruption, and you have to design methods of not having tension. One of the things I've done that's been useful is to add a pericardial pledget to the tip of the leaflet in a horizontal mattress fashion. Here's an example. I only do it when I'm very concerned about potential disruption, because it in of itself can cause distortion and a little bit of regurgitation in that region, but it can also prevent disruption of the tip of the leaflet and more severe regurgitation. And if you have very translucent leaflets in the region of the cleft closure, then one might consider adding in some primary pledgets to manage that. If you have issues of leaflet disruption, it's important to add in an augmenting patch. This is one strategy of adding in an augmenting patch. Here's another strategy of adding in an augmenting patch, and I will show you this example on the right. Here's a patient who arrived on ECMO with a disrupted leaflet. We took the patient to the operating room and augmented the cleft and added in an artificial cord. And we initially came off bypass with too much regurgitation. We adjusted it with a second pump run, and then were able to get a survivable situation. And the child was discharged home, but ultimately will need to come back eventually, probably for re-repair or replacement. So if you look at repair, what are the grades of repair? Well, an optimal repair has essentially no gradient and no regurgitation. So you have increasing gradients on the left, you have decreasing regurgitation on the right. A good repair, one that's entirely acceptable, is a gradient of 3 to 4 with mild to mild plus regurgitation. But even this you might want to improve if you have the option of improvement. When do you need to for sure consider reoperation? At the time. If you have a gradient of 5 to 7 or moderate regurgitation. And if you don't improve that, longer term, you will have a higher incidence of needing reoperation. If you have a gradient of 7 to 9 or moderate to severe regurgitation, you definitely want to revise if you have the option. They may be ventilator dependent or require ECMO, but some of them with good medical management will be able to be discharged from the hospital. And certainly if you have a gradient of 10 and severe regurgitation, this isn't survivable, and they may well need to be on ECMO for a recovery period before you begin to reoperate for them. So there are 4 key questions you need to ask when you're talking about reoperating or accepting the repair or not. Number 1, is it survivable? Number 2, have realistic expectations for that valve been met? And if they have not, can you do something to improve the valve? And then finally, really importantly, can the myocardium tolerate further ischemia? So if the answer is you can improve it and the myocardium can tolerate further ischemia, then you should work on further repair. If it's not survivable and you cannot do something to further repair, or the myocardium cannot tolerate further repair, then consider ECMO and returning for either further repair or replacement when the function is better. So let's go through a couple examples. Here's a patient where the first pump run was an adequate repair, but it wasn't as good as we tested with saline, and we knew there was more we could do. So we went back, we added in a little bit of adjustment to the cleft and further annuloplasty tightening. And you can see we went from an adequate repair to what is a very good repair. And that was worth going back on for. Here's a situation with terrible regurgitation coming in. We spent an enormous amount of time on a cross clamp trying to adjust and find the best solution we could. And here is what I would consider a survivable repair. But I knew that if we went back on, we could not improve anything. And so this was as much as we could get for this particular valve, and we accepted it, and the child ultimately did well. Although obviously when you have this quality of repair, it's more likely that years down the road, you'll be coming back for reoperation. So when do we use ECMO? When there are failed multiple attempts at repair and you have unsustainable physiology. Failing physiology after primary repair, in other words, you need to get them on ECMO before you take them back to the operating room. Occasionally, if there's catastrophic failure early on, you will need to put them on ECMO if that occurs. Or ECMO for safety and or recovery, which sometimes can be a bridge to having a successful outcome. Always remember that we now have the option of putting in a melody valve, which has really advanced our potential for rescue. Here's an example in the literature out of Austria, where they replace both AV valves with a melody valve. And this is the Imani technique that is very successful for these patients. So in summary, I would say quality of repair impacts long-term outcome. We should shoot for an optimal repair, but it may vary with the substrate that they present. What is the best you can get for that patient? And consider revision at the time if the heart can tolerate it, and if you think you can improve it based on what you did initially. Augmentation strategies for initial failed repairs can be helpful. This is important because it precludes the issue of tension. And finally, we have replacement as a rescue option.
Well, thank you, Glenn. As always, a very erudite and organized presentation with practical advice, super helpful for everybody. Could you talk a little bit about the role of annuloplasty, the decision-making around when to employ it, and then also maybe that's a part of this topic, but also the role of if you have a patient with what is predominantly central regurgitation, in other words, it's not necessarily related to a torn suture or an irregular edge, but just an unacceptable amount of central regurgitation. The role of mural leaflet augmentation versus annuloplasty to address that particular problem.
So I would say the first thing is, what was the quality of the valve coming in? So if the quality of the valve coming in is good, and you're having those problems, it's distortion that's caused the issue. And so hopefully you've done the operation in a way that you can fix that distortion. So the most common mistakes I've seen, and the joy of having worked with, having to learn it myself and then helping a number of other people learn it, is that the most common mistake is getting the cleft wrong. And that will cause a significant amount of central regurgitation. So often you can figure out that, oh, it's a serpiginous cleft and you didn't quite get the line of coaptation right, and you can adjust it and make it okay. And you can spend a lot of time adjusting the tip of the cleft closure to actually get rid of that. So, and then I would add, if that doesn't work, or if there's still a little bit of central regurgitation, then local annuloplasties, either at the anterior aspect of the mural or the posterior aspect of the mural leaflet, often takes care of that residual issue. And the only thing you have to look at is what kind of gradient are you going to leave. So that would be the common decision-making process I would go through. If you walk in with a massive amount of regurgitation, then you have to ask, what's the leaflet morphology that's causing the regurgitation? And if it's leaflet deficiency, or if it's somebody that's presented late and you have leaflet contraction, that's where you start thinking about primary leaflet augmentation as something that you need to do. I think that's pretty rare unless you're seeing patients come in late.
And in the conduct of routine or elective AVSD repair, the role of annuloplasty, the decision about annuloplasty, or is annuloplasty not typically a part of your routine primary repair technique?
Almost always I put in one local annuloplasty suture, and that seems to be the final little touch that's needed to get rid of that central regurgitation. There's no way to do this operation without changing the leaflet's sum, whether you're doing a no patch technique or whether you're doing a 2-patch technique. You are altering the leaflet sum, and so you have to make some adjustment for that. So the question is, what's the gradient that you leave? And I would say a gradient under 4 is no problem at all. 5 to 7, you're starting to think maybe you tightened it a little bit too much.
Do you have a trick about sizing? For instance, a Z-score, or how do you assess that?
So what's the normal size for a particular valve? And usually 1 or 2 millimeters smaller than that is not a problem. 2 millimeters usually.
Very good. One question, and then we'll probably have to move on, from Dr. Al-Kindi. Any tips regarding leaflet augmentation or cleft augmentation, and how much do you need, how much material do you need in the augmentation? How do you figure that out?
Honestly, I just eyeball it. You say, what's the gap or what's the potential gap? And then you leave enough space for suturing and a slight redundancy. And the big thing is no tension. If you're putting tension in on these leaflets will tear unless you're dealing with, really, really thick leaflets. So annuloplasty techniques help take away the tension. Augmenting techniques help take away the tension. Those would be the places that I'm looking to augment and set up everything so that it's addressed around that point of tension.
So one might say redundancy, but not a lot of redundancy or something like that.
That's right. If you create too much redundancy, you actually create stenosis of significance. And that's one of the problems with augmenting leaflets, is that you will create some gradients with that augmenting from the entire kind of superior and inferior bridging leaflet. Not so much if you're augmenting the cleft, but then you're likely needing to add in a chordae. So that raises the level of complexity there, but can be a means of getting out of trouble for sure.
And preferred material for augmentation?
I personally use glutaraldehyde treated autologous pericardium.
Well, once again, thanks, Glen, so much for your contributions and a great talk. And to the audience, we're lucky to have Glen returning next month to talk about these same issues in complex AVSD.
All right, happy to join. Thank you.
Perfect. So we'll move on to our next speaker, who's Dr. Zohair Al-Halees, who's a distinguished adult and pediatric congenital heart surgeon at King Faisal Specialist Hospital and Research Center in Riyadh in Saudi Arabia, and also adjunct professor of cardiac surgery at the American University of Beirut Medical School in Beirut, Lebanon. And he'll be speaking about repair of partial AVSDs, including early repair and left atrioventricular valve reconstruction.
Good morning, good afternoon, good evening, wherever you are. It's a pleasure to be here for the 10th curriculum webinar for the World University, which is dealing with the atrioventricular septal defect, the basics. My task is to talk about the repair of the partial atrioventricular septal defect, including repair of the left-sided atrioventricular valve. The natural history data for this lesion are not really well documented, but probably are very similar to that of a secundum atrial septal defect. However, infants with partial atrioventricular septal defect presenting in infancy have a poor outcome, and that is mainly because of the associated risk factors that bring these infants to early attention. If you want to consider surgery, Generally, most of the cardiologists believe that it's an elective surgery and that probably the repair should be planned at preschool age. However, in patients with significant mitral valve regurgitation, there might be symptoms that require early surgery. However, in patients who are asymptomatic and have mitral valve regurgitation, one may contemplate delaying the surgery till the patient is a bigger size, bigger weight, as there is always a possibility that the valve repair may fail and the replacement may become necessary. And as we all know, in this age group, mechanical valve replacement with its potential drawbacks is the only option. And that's why maybe delaying the surgery might be beneficial for the patient. Replacement of the mitral valve may be required from the get-go in the presence of severely dysplastic mitral valve. In general, the risk of hospital death is low, and it should be less than 3%. And I'm sure in many centers nowadays, it's the risk of hospital death is negligible. Looking at the reoperation required for mitral valve, it probably is in the range of about 10 to 15% in literature. There are some associated cardiac anomalies that have surgical implications in the repair. Most common are the presence of a persistent left superior vena cava with without unroofed coronary sinus. Of course, one has to be very careful about the unroofed coronary sinus and check that in every case. Interrupted inferior vena cava, presence of a common atrium, presence of anomalous pulmonary venous drainage, pulmonary valve, pulmonary artery stenosis, any kind of right ventricular outflow tract obstruction may be associated with the lesion, WPW syndrome, and occasionally congenital heart block. In terms of symptomatology that may push for earlier surgery, it's mostly in patients who have significant mitral valve regurgitation, and those patients may exhibit symptoms of congestive heart failure or growth retardation. And very small percentage exhibit significant symptoms in infancy, and those, as we have mentioned earlier, have the poorer prognosis in long term. In this particular disease, pulmonary vascular disease is usually uncommon. If we want to look at the objectives of the surgical repair of the partial atrioventricular septal defects, it's really the closure of the interatrial communication and the restoration and preservation of the left AV valve competence. These objectives can be accomplished by careful approximation of the edges of the valve cleft with interrupted non-absorbable sutures. The repair is completed by closure of the interatrial communication, usually with an autologous pericardial patch, whether fresh or treated with a glutaraldehyde. Personally, I prefer fresh autologous pericardium for this kind of repair. And of course, one has to be careful avoiding injury to the conduction tissue. The repair, this kind of repair results in a 2-leaflet valve. And I'm sure that some of you would probably refer to what was called in the common AV valve or in the common AV septal defect, that the left-sided AV valve is considered as a tri-leaflet valve. I think this was a concept that was proposed by Professor Carpentier at one time, and that the cleft of the left-sided AV valve is viewed as a commissure. And if you are kind of taking that into account, then surgical repair demands that this commissure be left unsutured and that the various annuloplastic sutures or techniques should be placed to promote coaptation of the 3 valve leaflets and make the valve competent. In general, I think most of the surgical repair at this stage or at this time would consider that the valve is a 2-leaflet valve rather than a 3-leaflet valve. This is just a depiction of how the anomaly looks from the surgical side. You can see here the primary atrial septal defect. the tricuspid valve on top, and the left-sided AV valve or the mitral valve at the bottom with the cleft in the anterior leaflet. The repair entails, of course, closure of the cleft of the mitral valve by interrupted sutures, and then using the pericardial patch to close the atrial septal defect. And the final stage before the closure of the suture line of the ASD patch, de-airing of the left side. Occasionally, if some may be worried about the coronary sinus and the heart block, and you may want to leave the coronary sinus draining to the left atrium to be away from the conduction tissue and avoid heart block. Sometimes there are additional maneuvers that are required to make the valve competent. So in addition to closure of the cleft, as we see in panel A, there are occasionally elongated chordae that will cause prolapse of some segments of the valve. And these can be fixed by either applicating the papillary muscle or by folding the elongated chordae into the papillary muscle using a pledged suture. A repair also may require additional annuloplasty. Most of us would probably utilize suture annuloplasty in this age group to promote growth or to allow growth of the valve in the future. However, if the child is larger size or the valve annulus is good and there is no worry about inducing stenosis, any type of a ring or a band can be utilized additionally for the repair. Occasionally, the edges of the cleft are very thickened and can be excised, and the repair can be, and the valve, the leaflet repair can be done with interrupted suture. And occasionally, the gap can be large enough, and if that is the case, then a patch of, again, autologous pericardium, whether treated with the glutaraldehyde or fresh, can be utilized to augment the anterior leaflet. One, however, has to be careful that the patch is not too large, as it will require support with chordae. And if that is the case, then you may want to add Gore-Tex chordae to support that additional patch that you have used to augment the leaflet. And the repair can, of course, be completed by using a partial ring or a complete ring if required. Though this is not a valve that shows an AV septal defect, but just the principle is sometimes the posterior leaflet may be deficient, and that again can be augmented to maintain a larger surface of coaptation with the valve. And again, for this kind of augmentation, an autologous pericardial patch is utilized. Also, the utilization of Gore-Tex chordae to support any flail part of the valve can be utilized in maintaining or in repairing the valve to maintain competence. Very occasionally, and this we have encountered this in in very few of our patients actually, the presence, despite the presence of a cleft in the anterior leaflet, the left-sided AV valve is a double orifice, and one has to be very careful in repairing those valves as they can become very stenotic. Also, we find it very difficult in these valves when you repair them as a double orifice to be able to, when you do the post-operative echocardiogram, to be able to quantitate the amount of residual stenosis because of the flow of the blood through two separate orifices. Sometimes it's very difficult, and the echocardiographer may tell you that the valve is stenotic. But these are very challenging to repair, but nevertheless, they are amenable to repair. This is a kind of valve that you can see significant AV valve regurgitation in a cleft in the anterior leaflet of the mitral valve. And with the repair, you would hope that you will get this kind of result with no significant residual mitral valve regurgitation and with a good inflow with no stenosis of the AV valve. And this is what we always aim for. So the essence of surgical repair of partial atrioventricular septal defect is the two major things: is the left-sided AV valve or the mitral valve repair, and most of us would use this as a bileaflet rather than a trileaflet AV valve. And of course, the primary atrial septal defect closure, usually with an autologous pericardial patch. If for whatever reason the autologous pericardium is not available, any type of material can be utilized, whether bovine pericardium or equine pericardium or Gore-Tex patches. A need for further surgery actually revolves around the durability of the mitral valve repair. As we have mentioned earlier, it is reported that mitral valve repair may be required in about 10 to 15% of patients, as there might be recurrence of the regurgitation. Thank you.
Thank you, Zohair, for an excellent presentation and great overview of what partial AVSD looks like. I think in recent conversation, there's been some literature regarding the advisability of routine repair of partial AVSD in infancy. But as you alluded to in your talk, I think most people would view repair of partial AVSD as a relatively elective operation in somewhat older patients. In your practice and in your conversation with cardiologists, what would you identify as the optimal age for repair of partial AVSD?
As a matter of fact, maybe if the patient has no symptoms or whatever, it's just like any time before 2 years of age is okay. We try and do most of our repairs before 2 years of age for most of the lesions, like every other institution. Very rarely we encounter patients that maybe a Down syndrome with malignant pulmonary hypertension that may require intervention earlier to avoid the consequences of the pulmonary hypertension. But I think most of the patients, anytime before 2 years of age is acceptable.
Good. Well, we don't have any other specific questions. So since we're running a little short on time, I think we should probably move on to the final talk, which is by Dr. Orr, who will, I guess, introduce herself.
Yeah, so I had the privilege and opportunity of giving the final talk. So I'm a pediatric and adult congenital heart surgeon working in Sydney, Australia with Ian Nicholson. So I'll be covering the early and late outcomes following repair of AVSDs, including reoperations. I would like to thank the organising committee for the opportunity to present this talk. It is an honour to be part of the World University Initiative. I have no disclosures. This talk will provide an overview of outcomes following repair of atrioventricular septal defects, focusing particularly on complete atrioventricular septal defects and AVSDs occurring as an isolated lesion, although we will touch on outcomes following repair of complex AVSDs. Outcomes that will be discussed cover both those that occur early within 30 days of surgical repair and those that occur late after this time period, usually following hospital discharge. Outcomes can be broadly categorized as survival, residual or progressive lesions, and the need for reintervention to address these lesions, bearing in mind that some lesions, such as atrioventricular valve regurgitation, may remain stable over time and not require reintervention. Atrioventricular septal defects have unique anatomic features that predispose the development of new or recurrent lesions following surgical repair. In addition, the surgical repair strategy inevitably changes the intracardiac dynamics and puts the conduction tissue at risk. Relevant anatomic features include the common atrioventricular valve, unwedging of the aorta with associated elongation of the left ventricular outflow tract, and the abnormal position of the atrioventricular node and bundle of His. The surgical repair importantly changes the loading conditions and dynamics of the left atrioventricular valve and flow dynamics to the left ventricular outflow tract. Consequently, hearts with atrioventricular septal defects are predisposed to developing left atrioventricular valve dysfunction and left ventricular outflow tract obstruction following surgical repair, in addition to the risk of atrioventricular conduction block. The time course of development of these lesions depends on the underlying lesion. Left atrioventricular valve regurgitation can develop at any time following AVSD repair, with an early risk period within 30 days of surgery, and then a progressive occurrence over time during long-term follow-up over 20 to 30 years. In contrast, left ventricular outflow tract obstruction rarely develops within 5 years following AVSD repair, but can be a little bit earlier after partial AVSD repair. Atrioventricular conduction block is usually procedure-related, but can occasionally develop de novo during follow-up. In terms of outcomes within 30 days of AVSD repair, operative mortality in the current era is reported at 1 to 3% internationally across single and multi-institutional studies. Early reoperation occurs in 1.3 to 6.8% of patients, most commonly for left atrioventricular valve regurgitation. Other causes for early reoperation include residual septal defects and implantation of permanent pacemakers. Overall survival in the long term following AVSD repair is pretty good at more than 80% at 20 years of follow-up across most studies. Freedom from reoperation is around 75 to 80% at 20 years. Late area intervention is again most commonly for left atrioventricular valve regurgitation, which is either progressive or recurrent, with left ventricular outflow tract obstruction being the other most common indication. Again, residual septal defects can prompt reintervention, but this is usually in association with either left atrioventricular valve dysfunction or left ventricular outflow tract obstruction. One reoperation is a marker of risk for subsequent reintervention, and there are some individuals who will require multiple reinterventions over time, often separated by several years during long-term follow-up. Indications for reintervention can include redo left atrioventricular valve surgery, the development of recurrent left ventricular outflow tract obstruction or de novo left ventricular outflow tract obstruction after redo left AV valve repair or replacement, and once again, the risk of implantation of pacemaker for management of atrioventricular block. As mentioned, overall survival following AVSD repair is very consistent across both multi and single institution studies, with survival of at least 80% at 20 years and overall freedom from reoperation of 70 to 75% at up to 30 years of follow-up. Long-term outcomes following AVSD repair have been extensively investigated across many single and multi-institutional observational studies that have identified predictors of reoperation following AVSD repair. The most consistent predictor of reoperation following repair in these studies is the presence of moderate or greater left atrioventricular valve regurgitation early following AVSD repair. Other factors include older age at the time of AVSD repair, preoperative severe left atrioventricular valve regurgitation, left atrioventricular valve dysplasia, and deficiency of Meryl of leaflet tissue. Complex AVSD, as described here, is also a risk factor for reintervention. Importantly, Down syndrome and closure of the zone of apposition in the left atrioventricular valve are both protective against the risk of reoperation. This study by Wetter et al. Nicely demonstrates the impact of closure of the zone of apposition of the left atrioventricular valve on both freedom from reoperation and overall survival following AVSD repair. The Texas Children's Group in this study demonstrate the impact of AVSD complexity on the risk of reoperation, with complex AVSD being associated with a hazard ratio for reintervention of 2.6%, which was statistically significant. Survival was similar across the two groups in this large study, regardless of whether they were isolated or complex AVSDs. The most consistent risk factor across studies for mortality following AVSD repair is repair in an early surgical era. Other predictors of mortality during follow-up include complex AVSD, the need for left atrioventricular valve reoperation, and prior pulmonary artery banding. Although reoperation continues to be an issue even in the current era during long-term follow-up after AVSD repair, long-term survival following complete AVSD repair continues to get better with each decade, as you can see here, consistent with improvements in perioperative care and surgical technique. There is increasingly evidence to suggest that early operation to repair AVSD at less than 3 months of age, and even in the neonatal period when required, is associated with good long-term outcomes in terms of survival and freedom from reoperation, as demonstrated by this recent data from Royal Children's in Melbourne and Lund University in Sweden, both published this year. The group at the Royal Children's in Melbourne have also demonstrated that early primary repair is associated with better long-term survival than initial palliation with pulmonary artery banding, including in this propensity matched group, but that freedom from left AV valve reoperation is fairly similar over time, regardless of the age at repair. In our Australian multi-institutional study, we also demonstrated that interim palliation with pulmonary artery banding was associated with worse overall survival in the long term compared with primary repair. Focusing briefly on partial and transitional AVSDs, survival following repair of these AVSD subtypes is excellent, and the need for reoperation is similar to that following complete AVSD repair for both left atrioventricular valve dysfunction and left ventricular outflow tract obstruction. Importantly, repair in infancy is associated with a greater likelihood of reoperation, particularly for left ventricular outflow tract obstruction, and this is a common finding across studies. In conclusion, the development of new lesions following atrioventricular septal defect repair is anticipated but not inevitable. Similarly, operative reintervention is anticipated, but hopefully risk is minimized by careful and measured surgical technical approaches at the time of primary repair, including careful attention to septation of the common atrioventricular valve and potentially borrowing of leaflet tissue from the right AV valve to supplement the anterior left AV valve components. Closure of the zone of apposition should be performed in most cases unless there is an anatomic or technical contraindication. It's important to ensure the ideal VSD patch height for double patch repair, and the selection of optimal repair technique depending on operator experience and preference and underlying anatomy is important. Finally, given that postoperative left atrioventricular valve regurgitation is a strong predictor of reintervention and that left AV valve stenosis is exceedingly rare during follow-up, consideration should always be given to performing focal annuloplasties when repairing the left AV valve at the time of initial AVSD repair in order to optimize left atrioventricular valve competence, even at the expense of a small degree of stenosis at the primary operation. Early primary AVSD repair at less than 3 months of age is achievable in the current era with excellent long-term outcomes and may have benefit over interim palliation with pulmonary artery banding and subsequent stage repair. And most importantly, lifelong follow-up with echo screening is essential following AVSD repair to detect and manage residual and progressive lesions in a timely fashion, as many of these patients will be asymptomatic until quite late in the course. Once again, thank you to the organizing committee for the opportunity to have presented this talk.
Great talk, Yishay. That really covered that topic extremely well. There's one question. Is there any insight knowledge that you have about the right AV valve outcomes regarding the right AV valve? This question comes from Dr. Saeed.
So I guess in our experience and also in the literature, it's very rarely an indication, like an isolated indication for reoperation. And I guess if you've been able to manage all the other things okay, as we know, some right AV valve regurgitation with normal pulmonary artery pressures is often a very well tolerated lesion at the mild to moderate level. So it's often not reported on very much, and we didn't find a great deal of detail about it looking at our national outcomes. And then very occasionally it's addressed in terms of reoperation for the left AV valve or residual septal defects. It's sort of an additional procedure added on, but not put a lot of emphasis on. So I think what we all find is how tolerant the right AV valve is to having a bit of leaflet tissue borrowed from it. And you know, sometimes you've got such deficient tissue over the septum, you wonder how the valve works, but it seems to somehow, because the anterior leaflet components are fairly generous. So it doesn't seem to be much reported on nor too much of a problem.
You spoke a little bit about closure of the zone of apposition and the historical evidence for that. I think that's a pretty widely accepted principle these days, and sort of quote unquote routine closure of the zone of apposition, an accepted principle. However, you're probably aware of your fellow countrymen there that have taken a contrarian stance to that. What would be, so in other words, I think the group in Melbourne has, talked about equivalent outcomes in patients with or without closure of the zone of apposition. What would be your observations about that?
So again, actually closing the zone of apposition didn't, whether it was done or not, didn't seem to be a risk factor for left AV valve reoperation. So I think it comes back down to surgeon-specific techniques. And if you looked in the fine details of the paper that the Melbourne group have presented, they actually anchor the apex of the zone of apposition in the septal region. So there's some, almost tiny bit of partial closure. So I think, as Glen says, they're taking tension off that zone of apposition by how they anchor it to the septal patches. And when you speak to the guys in Melbourne, it's very surgeon specific as well. And as we know, in some units, the canals are specifically referred to, one or two surgeons in the unit, and those surgeons get really good at doing them and have a really good feel for them. So it's very interesting. There's a lot of behind the scenes detail. And the more I've spent looking at this, the more I realize that there's much more art than science to canal repairs, unfortunately.
I think you put your finger on the issue with that analysis, which is partial closure was not called anything. Partial closure
Yes.
was in the left open group. And so I think that the take home perhaps for me is we don't necessarily close all zones of apposition to the tips. Partial closure does have a role. Very good. Well, we don't have any other questions from the group. We do have a few minutes left, so we could circle back to some questions from the chat room that were left unaddressed. There's a couple actually for Dr. Mamorare. One from Dr. Kamani about the timing of pulmonary artery banding in locales where primary repair is not available. So this would be in a setting wherein primary complete AVSD repair is not possible. What would be the optimal time to be banding a child presenting with complete AVSD?
Afternoon. In our setting, we don't have an optimal time for doing a band. The only reason we do a pulmonary artery band is because the child has got one or other predisposing factors that actually prevent us from doing a complete repair. And by complete repair, I mean trying to fix everything, the VSD, ASD, the mitral valve. If a child is well and is not in excessive CCF, we would wait until they're about 3 months old. And that gives us a good way to start off with. And then we would go ahead and repair them at anything over 3 months. We obviously don't want to wait too long because of the early onset of pulmonary hypertension in this group of patients, especially, as I said, in our Down syndrome babies. If a child comes in and is a complete AVSD, which is complicated by failure to thrive, ongoing infection, chest infection, or has got other congenital defects, at that point in time, we would go ahead and effect a pulmonary artery band and watch them with a pulmonary artery band in position. And the objective would be that we reduce the pulmonary blood flow, they get over the infection, they gain a bit of weight. And from our point of view of putting them on bypass, they in a much healthier state, as opposed to just rushing them to theater and then being in a position where post-operatively they have ongoing lung sepsis and they don't do well. So to answer that question, I would say we don't have a specific time for doing a pulmonary artery band. If a child is not in CCF, we arbitrarily chose 3 months and then would repair them after 3 months. If a child has got any other contraindication, we would then do a band at the time when they present with that contraindication.
I have a couple of points. May I?
Of course, thank you.
Yes, the question of pulmonary artery banding in the presence of preoperative AV valve regurgitation. Do you see increase in the amount of regurgitation when you band the child because of the increased right-sided pressures?
In our experience, this has always been something that you have to look at an individual patient. Whereas the ordinary way one would look at it is that you'd see more regurgitation. It doesn't always happen. Sometimes by just doing a band, increasing your anti-failure treatment and optimizing things, we actually see a reduction in the regurgitation of the valve. But it's a very unpredictable thing to expect following your pulmonary artery band, because sometimes, as you rightfully say, you actually make it worse and it becomes a very difficult situation as to, is your band too tight? Do you have to go up with your anti-failure treatment? It can be very sort of unpredictable as to whether you're going to have worsening of the situation in terms of your regurg or not.
Thank you. I just have one other point. Does anybody in the panel have any other tricks to test the valve at the time of the surgery for repairs, or does everybody use the water test to see the competency of the valves? Are there any other tricks than that?
I don't know of any other ones. I don't know if anybody else does.
Yeah. The reason I'm asking, because sometimes you have a patient where you actually your water test is 100% tight, and then you go out, you go off pump and do the echocardiogram, and the echo shows you even sometimes significant regurgitation that would push you to go back for another pump run. So we're just wondering if somebody has any other tricks for testing at the time of the surgical repair. David, I just noticed in the chat box that was one of the questions somebody mentioned. Does anybody use iodine vapor to visualize the conduction tissue? I found that interesting, but I've never heard of it. Does anybody know anything about that?
Yeah, thank you. I was going to bring that question up, so that is good. Yes. I don't have any experience with that, but do any other of the panelists? That came from Dr. Bitaguru, I believe. No. Well, all right. It is 10:30, and that will concludes our webinar for today. I want to thank all of you for attending our 10th curriculum webinar, AVSD, the Basics, and especially I want to thank our esteemed colleagues for sharing their time and effort with us today. I thought it was an excellent session. I want to remind everyone that the webinar was recorded and is available on the WUPCH website. Please join us next month on August the 21st for a continuation of our exploration of AVSD, atrioventricular septal defect, complex types and issues. Thanks again for attending and have a great weekend.